To the Kanski lecture series, and this is going to be the uveitis part A, and in this part we are going to discuss about the sarcoidosis. So sarcoidosis is basically a non-caseating granulomatous inflammatory lesions. So introduction. Sarcoidosis is a chronic disorder of unknown cause manifesting with the non-caseating uh, granulomatous inflammatory foci. It can affect any organ system, but the lungs and the lymph nodes are the most commonly involved. So basically, the most commonly involved are the lungs and the lymph nodes. It is frequently 10:1 affect patient of black than white ethnic background and is more common in colder climates. It is one of the most common systemic associations of uveitis. So, what is the systemic features? Presentation: respiratory system symptoms, cough, shortness of breath on exertion, and constitutional symptoms, malaise, arthralgia, each occur in about 50% of the patients. Lofgren syndrome is an acute presentation carrying a good prognosis, characterized by the triad of the erythema nodosum, bilateral hilar lymphadenopathy or chest X-ray, and polyarthralia, usually seen in women. So basically, the patient will present about cough, shortness of breath, and some other features like malaise, fatigue, and arthralgia, and it occurs about 50% of the patient. So what is a Lofgren syndrome? Lofgren syndrome is basically the acute presentation which is carrying a good prognosis, and it has a triad. It means that there will be the erythema nodosum, bilateral hilar lymphadenopathy or chest X-ray, and polyarthralgia. So three things: one is the skin lesion, which is the erythema nodosum; second is the lung bilateral lymphadenopathy; and third is the polyarthralgia, which is basically the joints problem. A minority of the patients are asymptomatic. Incidentally, abnormal chest X-ray diagnosis may be made as a result of investigations of the extrapulmonary inflammation such as uveitis. So this is a figure 12.26a. A is showing sarcoidosis. A is showing bilateral hilar lymphadenopathy. B is showing erythema nodosum, and C is showing lupus perineo of the cheeks. Next is the basically lung diseases ranges from the, so basically sarcoid can affect any organ system, but most commonly is the lungs and lymph nodes. Lung disease ranges from mild parenchymal infiltration to severe pulmonary fibrosis. So just a mild infiltration to fibrosis. Skin lesions are seen in 25% of the patient and can include erythema nodosum, tender erythematous plaque, typically involving the shin. So erythema nodosum is a erythematous reddish plaques that are involving the shin. Lupus perineo is indurated voluptuous lesion over the exposed part of the body such as nose, cheeks, fingers and ears, and granulomatous papules or macules. Neurological disease is rare, but meningitis and cranial nerve palsies may occur. Pituitary involvement may lead to hormonal abnormalities. So it can also cause meningitis and cranial nerve palsies as well. Cardiac involvement is relatively uncommon, 5% clinically, but is critically important as it may lead to arrhythmia and sudden death. Lymphadenopathy. Enlargement of the superficial node is sometimes the initial clinical manifestations. So what are the ocular features of the uh, sarcoidosis? So it causes the granulomatous uveitis. One thing that is always remembered: nodules with the case of sarcoidosis. So you can find nodule in any part of the eye. So we will see that there are usually seven criteria of the sarcoidosis of intraocular. Ocular inflammation occur in 25 to 70% of the sarcoid patient, depends on the ethnicity. Granulomatous anterior uveitis is the most common manifestation. So anterior uveitis, which is granulomatous. Blindness can occur if not adequately managed. Acute anterior uveitis typically affects patients with acute onset sarcoidosis. Chronic anterior uveitis, typically granulomatous, tend to affect older patients with chronic pulmonary disease. The International Workshop on Ocular Sarcoidosis, reporting in 2009, identified 7 key signs in the diagnosis of the intraocular sarcoidosis: button fat capes and or small granulomatous capes and or iris nodules, copy or bisacca. So First of all, starting with the cornea, there is going to be the mutton fat capes, which is like a granuloma on the endothelium, and on the iris there are going to be the nodules, which is coipi, which is the nodule at the pupillary margin, and busaka, which is the nodule on the iris stroma. So this is one thing that is present. Second thing is trabecular meshwork nodules. Trabecular meshwork nodules and or tent shape, so it can occur with or without tent shape peripheral anterior synecdoche. Third is the vitreous opacity. So this you can also get, it is a kind of nodule, snowball and a string of pearls. Fourth is the multiple chorioretinal peripheral lesions, active or atrophic. So peripheral lesions, which is chorioretinal, choroidal lesions are uncommon and vary in appearance. So whenever there is a choroidal lesion, there is going to be the yellow, and when there is a retinal lesion, it is going to be the white. So multiple small pale yellow infiltrates, sometimes with a punched out appearance, are commonest and are found more numerous inferiorly. Multiple large confluent infiltrates are less common. Multifocal choroiditis carries a poor visual prognosis even after the resolution of the activity as a result of secondary choroidal neovascularization associated with macular or peripapillary chorioretinal scarring. Retinal granulomas may also occur as a small, discrete, small yellow-white lesion. So first is that there is going to be the multifocal choroiditis that can be present with the sarcoidosis, and even if it carries a poor visual prognosis. Why? Because of the C and V that forms after that, and which causes the macular and peripapillary chorioretinal scarring. Next is the nodular and or segmental periphlebitis. So this is going to be 1, 2, 3, 4, 5, fifth criteria, which is the nodular and or segmental periphlebitis plus minus candlestick stripping and or retinal macroaneurysms in an inflamed eye. So vessels are going to be affected in the case of a sarcoid. Periphlebitis appear as a yellowish or grey-white perivenous sheathing. Perivenous exudate, referred to as a candle wax stripping, and Tachys de Bogi are typical of the severe sarcoid periphlebitis. Occlusive periphlebitis is uncommon, but peripheral retinal neovascularization may develop secondary to the capillary dropout. In black patient, it may be mistaken for proliferative sickle cell retinopathy. So if there is like occlusive periphlebitis, it can cause the retinal neovascularization. So veins are getting affected. So let's see what we have discussed about 5. First is very A is showing large granulomatous mutton fat capes. B is showing large iris nodules. You can see coipi nodules and Busaka nodules. C is showing nodular involvement of trabecular meshwork. D is showing the snowball formation in the vitreous. Next is the choroidal and retinal involvement in sarcoidosis. A is showing choroidal granuloma. So this is a granuloma in the choroid. B is showing multifocal granulomas. C is showing confluent choroidal infiltration, and D is showing multiple small retinal granuloma, which is small yellowish white lesions. And 12.29 is showing periphlebitis in sarcoidosis. A is showing candle wax stripping, so you can see the exudates around the veins. And B is showing occlusive periphlebitis, and there is the disc edema. So the sixth one is now optic disc nodule or granuloma. So now we are going to discuss about the nodule on the optic disc or granuloma and or solitary choroidal nodule. Solitary choroidal nodules are less common than multiple lesions in sarcoidosis. Focal optic nerve granulomas do not usually affect vision. Persisting disc edema is frequent findings in the patient with retinal and vitreous involvement. And papilledema due to CNS involvement may occur in the absence of other ocular manifestations. So optic disc nodule can also occur in the case of a sarcoidosis. Now, seventh is that there is going to be nodule formation in the rest of the eye. Other ocular manifestations include conjunctival nodules resembling those of a follicular conjunctivitis, lacrimal gland infiltration, and dry eye, eyelid nodules, orbital and scleral lesions. Complications are seen, those typically seen in idiopathic uveitis, including cataract, glaucoma, posterior and peripheral anterior synecdoche, band keratopathy, vitreous hemorrhage, maculopathy, cystoid macular edema, epiretinal membrane, choroidal neovascularization, retinal detachment, and phthisis. So this is 12.31 is showing us the lacrimal gland involvement in a sarcoidosis, and B is showing lower lid granulomas. 12.30 is showing persistent disc edema with periphlebitis and macular edema. Now, next is the what investigations can you carry out in a case of sarcoid. In addition to the acquisition of the histopathological evidence, international um, workshop on ocular sarcoidosis judged the following 5 investigations to be significant value in the diagnosis of ocular sarcoidosis in a patient having a compatible uveitis. So if you are having a suspicion that a patient is having a sarcoid, so there are 5 diagnostic criteria that you can do to make the diagnosis clear. Number 1 is a negative tuberculin skin test in a BCG vaccinated patient, or in a patient having had a positive tuberculin skin test previously. So basically, in a case of a sarcoidosis, there is going to be the negative tuberculin test, especially in a BCG vaccinated patients and those who had previously had a positive tuberculin skin test. A tuberculin skin test is negative in most sarcoid patients. A strongly positive reaction to one tuberculin units make a diagnosis of the sarcoid is highly unlikely. Next is the elevated serum ACE level and or elevated serum lysozyme as described for investigation of acute anterior uveitis. Second is the blood test. They are going to be the increased ACE level with and you can say there is an increased lysozyme level as well. So both increases the specificity and sensitivity of the sarcoid. Number third is the chest X-ray showing bilateral hilar lymphadenopathy. Chest radiograph is abnormal in 90%. Abnormal liver enzyme test. Chest CT in a patient with a negative chest X-ray result. High resolution CT scan is of considerably greater value than other standard resolution imaging. So first is negative tuberculin skin test, second is serum ACE level, third is chest X-ray, fourth is abnormal LFTs, and fifth is a chest CT. Now you can do biopsy as well. So there is a fiber optic bronchoscopy with biopsy. Histopathological confirmation of sarcoidosis is almost always required before starting treatment. The lung is a common site from which to establish this in presence of a clinical or investigational evidence of pulmonary disease. However, more easily accessible superficial lesion should be chosen if available. So you can do fiber optic bronchoscopy and do biopsy. Then there is a thoracic endosonography, endobronchial or esophageal. So like with an endoscope you can do the ultrasound of the thoracic region as well. With needle aspiration has been shown in a large trial to be more sensitive technique than bronchoscopic biopsy. Miscellaneous biopsy site include superficial lymph nodes or skin lesion, conjunctival nodules, and lacrimal glands. Up to 75% of the enlarged glands are positive. If the eye is involved, vitreous biopsy is very helpful, CD4 or CD8 ratio. So you can take the biopsy sample from any kind of nodule as well. Other imaging modalities including MRI, cardiac and CNS imaging. MRI is less useful than CT for thoracic evaluation, PET scanning and occasionally whole body gallium scanning. Calcium and vitamin D levels may be abnormal depending on the disease pattern and level of activity. They're going to be the hypercalciuria is common pulmonary function testing. You can also do bronchial alveolar lavage fluid. BALF show characteristic changes. CD4 to CD8 ratio are T cells are the key indicator in the case of a PALF. Induced sputum analysis correlates strongly with PALF and is a non-invasive technique. So now there are 4 diagnostic levels were defined by the International Workshop of Sarcoidosis for Ocular Sarcoidosis. So there is like in VKH, there are going to be the definitive, presumed, and probable. So if there is a definitive ocular sarcoidosis, there is a biopsy supported diagnosis in the presence of a compatible uveitis. In a case of the presumed ocular sarcoidosis, biopsy is not done, but chest x-ray show bilateral hyaloid lymphadenopathy with the compatible uveitis. In a probable ocular sarcoidosis, biopsy is not done and there is no bilateral hyaloid lymphadenopathy or chest x-ray, but 3 out of 7 signs of the intraocular signs above and greater than 2 out of 5 positive laboratory tests indicates that it is a probable ocular sarcoidosis. Then there is a possible ocular sarcoidosis. The lung biopsy is negative. So in a probable, biopsy was also not done, but there was no bilateral lymphadenopathy in the chest x-ray. And in this case, there is a possible lung biopsy is negative, but criteria is high. Like there is a greater than 4 out of 7 signs in ocular and greater than 2 out of 5 laboratory tests, positive laboratory tests. It is critical that alternative cause of uveitis are adequately excluded by appropriate assessment and investigation. So how will you treat the case of a sarcoidosis? Corticosteroid have conventionally been the major treatment modality in ocular and systemic steroid sarcoidosis. So immunosuppressive are being used more commonly, particularly as a steroid suppressing agent, and in refractory disease, treatment should be initiated aggressively to prevent sight-threatening complication. Treatment of anterior uveitis and intermediate uveitis is approached in a stepwise fashion as for idiopathic inflammation. Posterior uveitis generally requires systemic steroid and occasionally immunosuppressive agents such as methotrexate, azathioprine, cyclosporine, and TNF inhibitors, for example, adalimumab. So for anterior, you can give topical steroids, and for posterior, you give the systemic steroids and systemic medications. Peripheral retinal neovascularization can be treated with scattered photocoagulation to the ischemic area demonstrated by FA. Cystoid macular edema may respond to topical NSAID. Cataract and glaucoma may require treatment. Inflammation should be suppressed prior to surgery, preferably for at least 3 months in case of a cataract surgery. So now next is the Behçet disease. So Behçet disease is also an autoimmune disease. Behçet disease is an idiopathic multisystem syndrome characterized by the recurrent aphthous oral ulcer. There is a genital ulceration and uveitis. So ulcers, genital, oral ulcer, genital ulcer, and uveitis is what is Behçet disease. Vasculitis is a key pathogenetic component and may involve small, medium, and large veins and arteries. Mortality is around 5% at 5 to 10 years, typically due to cardiovascular or CNS complications. The condition probably has an autoimmune basis and may be precipitated by exposure to infectious agent with subsequent cross-reaction. It typically affects patients from the Turkey, the Middle and Far East, the Asian Silk Road route, with a lower prevalence in Europe and North America. It is strongly associated with the HLA-B51. Very important for the MCU's point of view, HLA-B51 is associated with Behçet disease. The ethnic group with higher prevalence of Behçet disease also have a higher rate of HLA-B51 positivity. The peak age of onset is 3rd decade. So at the age of 30 years, reported gender prevalence varies with ethnicities. A transient hypopyon in a relatively white eye is typical of Behçet disease and juvenile idiopathic arthritis associated uveitis. So there is a hypopyon that is mobile. So what are the systemic features of Behçet disease? The International Study Group of Behçet disease, ISGBD, reporting in 1990, established criteria for diagnosis. So number one is recurrent oral ulceration characterized by oral ulcer at least 3 times in a 12-month period. So within a 1 year, if a patient is getting oral ulcer at least 3 times, then it is one of the criteria and it is recurrent. And plus at least any of these twos. Number one, second is any genital ulceration. Number third is ocular inflammation. Number fourth is a characterized skin lesion, erythema nodosum, pseudofolliculitis, acneiform nodules, papillopustular lesion, and E is a pathology reaction pustule. 20 to 48 hours after a sterile needle prick, 90% specify but often negative in a European and North American patient. So pathology test is basically you prick the patient with the needle, and after 24 to 48 hours there is a pustule formation. This is a pathology reaction. So number one is the recurrent oral ulcer is one of the most important criteria, and if any of the next four is present, then it means that it is a Behcet disease. Number one, genital ulcer, ocular inflammation, skin lesions, and pathology test. So if any of these two are present, then it means that the patient has a Behcet disease. Presentation does not always conform to the criteria above. Additional features include vascular lesion, aneurysm including pulmonary and coronary and venous thrombosis and thrombophlebitis. Arthritis occur in 30%, though arthralgia is more common. Dermatographia, similar to pathology reaction, indicates skin hypersensitivity and consists of the formation of erythematous lines following stroking or scratching. So in a case of vascular, vessels are affected, so they're going to be the aneurysms, especially in the pulmonary and coronary area, and they're going to be the thrombosis as well. Arthritis can occur in 30%, and dermographia is basically when you scratch the skin and there is a skin hypersensitivity. It is called dermatographia. Neurological manifestation 5%, such as meningoencephalitis of the brainstem, dural sinus thrombosis, and cerebral aneurysms. So aneurysms are being formed. So in a case of a neurological, they're going to be the sinus thrombosis, they're going to be the cerebral aneurysms, and they're going to be the meningoencephalitis of the brainstem. Gastrointestinal inflammation, especially ileocecal, hepatic, and renal lesions are relatively uncommon. So this is A 11.32. A is showing major aphthous ulcer and B is showing dermatographia. So what is the ocular features of a Behcet disease? Ocular inflammation occur in about 70%, tend to be more severe in men, and is presenting manifestation in 10%. Signs are virtually always bilateral eventually. So it is a bilateral disease. Relapsing and remitting acute onset pan-uveitis with retinal vasculitis and often spontaneous resolution even without treatment is a classic pattern of eye involvement. So there is going to be the pan-uveitis with vasculitis. Retinal vascular disease, vasculitis and occlusion is the main cause of visual impairment. So acute anterior uveitis is often bilateral, is typical. It is non-granulomatous. A transient mobile hypopyon in a relatively white eye is characteristic. So there is going to be the white eye, not a red eye in case of a Behcet disease, and they're going to be the uveitis. Vitritis may be severe and is universal in eyes with active posterior segment disease. So there is going to be retinitis, typically superficial white infiltrates that heals without scarring, may be seen during the acute systemic disease. There may be deeper, more diffuse retinitis, similar in appearance to viral inflammation. Exudative detachment can also occur. Inflammatory deposits analogous to KPs may be seen on the inferior peripheral retina. Retinal vasculitis, arthritis as well as phlebitis, in contrast to pure venous involvement in sarcoidosis, can manifest with sheathing, perivascular hemorrhage, and occlusion. Vascular leakage may give rise to diffuse retinal edema and CMO. Very important, in a case of a Behcet disease, both arteries and veins are involved, whereas in a case of sarcoidosis, only the veins are involved. And it occurs as a sheathing, hemorrhage, and occlusion. And even can cause retinal and cystoid macular edema. Optic disc hyperemia and edema, raised intracranial pressure can cause optic disc swelling and optic atrophy in bilateral disease. A Behcet disease, disc and retinal neovascularization may be seen in response to inflammation and ischemia. Uncommon manifestation include conjunctivitis, conjunctival ulcers, episcleritis, scleritis, and ophthalmoplegia from neurological involvement. End-stage disease is characterized by optic atrophy, retinal atrophy, and gliosis, and sheathing, attenuation, and ghosting of the affected vessel. The vitreous tends to be clear. Other complications include posterior synecdoche, cataract, glaucoma, and commonly retinal detachment, severe vision loss in male up to two-thirds of the patient at 10 years have been reported, but is probably much lower with aggressive management. The rate in women is about half that in men. So this is showing the ocular lesions in Behçet disease. A is showing hypopyon in white eye. B is showing retinal infiltrate. C is showing occlusive vasculitis. D is showing end stage disease. So there is optic atrophy in this case. Next is, what are the investigations that you can carry out in a case of a Behçet disease? HLA-B51, which is positive, Pethurgi test. Inflammatory markers such as ESR, CRP, complement levels, red cell count may be elevated. Thrombophilia screening is appropriate in some patients to exclude other causes of thrombosis. Effort delineates ischemic area and aids detection of posterior segment inflammation and monitoring of the severe disease activity. Laser flare photometry of the AC correlates well with the FA in determining the level of inflammatory activity. Superficial lesion biopsy, synovial fluid aspiration, and lumbar puncture may be used to help rule out alternative diagnosis. Systemic imaging may include brain MRI, MRA, CT, CTA, and conventional angiography to identify ischemia treatment. Immunosuppressants are the mainstay of treatment, but availability and expense will limit therapeutic options in many regions. Topical steroid alone may be adequate if rarely there is no trace of posterior segment involved. So basically, what is the treatment is the immunosuppressants are the treatment. So for the anterior uveitis, you can do topical steroids, and they are usually adequate. For posterior segments, you can give the systemic steroids, and azathioprine, which is dose is 2.5 mg per kg per day in combination, are recommended for initial management of posterior uveitis in a European League Against Rheumatism 2008 Behçet disease guideline. Steroid should be tapered slowly. Topical and or regional steroid can also be used, though there may be high rate of ocular hypertension with intravitreal steroid injection. Azathioprine may have a role in a prophylaxis. Then you can also give cyclosporin 2 5 mg per kg per day, or infliximab in combination with the azathioprine and systemic steroid is recommended by EULAR for severe eye disease. So if there is a severe eye disease, you can give systemic steroid and azathioprine with cyclosporin. So what is a severe disease? If there is a greater than 2 lines reduction in visual acuity and or retinal vasculitis or macular disease. So there are 3 categories. If there is a greater than 2 lines result visual acuity reduction, if there is a retinal vasculitis, or there is a macular involvement. A recent study recommended a single infliximab infusion in initial treatment of posterior uveitis. Hypertension, nephrotoxicity, and neurotoxicity are concerns with cyclosporin, which should be avoided in patients with CNS involvement unless it is determined that severe eye disease warrants the risk. Infliximab may lead to the activation of tuberculosis, and screening positive patients should receive prophylactic treatment isoniazid. So infliximab is one that is related to activation of TB, and if there is a positive patient, you can give the prophylactic isoniazid. Intravitreal administration is a novel alternative route of administration for infliximab. So this is a new treatment that has been going on for Behçet disease for intravitreal infliximab. Infliximab or adalimumab should be considered early for vision-threatening Behçet disease. In the case of American Uveitis Society recommendation, then there is an interferon alpha 6 million IU per day subcutaneously, initially gradually tapered with and without steroid is a EULAR recommended alternative to cyclosporin, infliximab, azathioprine as steroid regime for severe disease. So if there is a very severe disease and you are looking for alternative, you can give interferon alpha, and you give a 6 million IU per day subcutaneously, and then you gradually taper it. It should not be used in combination and as a thiopurine because of the risk of myelosuppression. Anticoagulants are not recommended. So that's it for the uveitis part 8. See you in the next lecture.